Good evening, everybody. Welcome to the March edition of Peer-to-Peer Academy. We are talking tonight about everything LAL and LAL plus. These two really dynamic lens options that we have that RxSight has provided us. Who, what, where, when, why, everything that there is to know about it. How do we use both of these to optimize outcomes for our patients? So tonight I am joined by two good friends, Eva Kim and Seamus Martin, both out of Icon Eye Care in Denver, Colorado. Thanks, guys, for joining. Appreciate the
excited to be here.
Cool. So first thing I want to go through, I want to run through a couple slides. So some new data points that RxSight has provided us, kind of differentiating, comparing the two, and highlighting the dynamic nature of both options. So what we're looking at here, let's get the slideshow working. So a couple of data points and then pearls we'll get to. So the reason we like the LAL, right, it allows us accuracy. Light adjustable lens eyes have a 14.5 times higher chance of hitting within a half diopter of target. Now, compared to standard monofocal lenses. Now, if you actually look at toric lenses, so the plot here over on the left, that's standard monofocal lenses, and then light adjustable lenses on the right. Looking at toric lenses, so taking into account an astigmatism or an astigmatic approach, we're actually getting about 8.6 times more likely within a half diopter of sphere and cylinder, based on postoperative refraction. So the LAL plus, for those who are unaware, it is very similar. It's probably more similar than it really is different compared to the light adjustable lens. The big difference is that it does have a little bit more central asphericity to it. So while you're really not giving a whole lot up, you're really not inducing a whole lot of negative, what you are getting out of that is a broadened depth of focus. And so we can see that in the defocus curve. So the advantage here is that we're improving our uncorrected near visual acuity. And what tends to happen, and especially my clinical appearance, I'm sure Seamus and Eva, you guys can probably contribute here too. Both eyes work more as a team. You're preserving depth of focus. You're preserving binocularity, and isometropia is less of an issue. So for patients who come in and they're like, well, man, I haven't worn my contacts, monovision contacts were just a disaster for me. Those patients do very well with the light adjustable lens, and they do arguably even better with the light adjustable lens plus, because you are preserving more depth of focus, and both eyes work better as a team. So getting down to the nitty-gritty, the numbers. This is coming from several studies. So there's the FDA post-approval study. There's 335 eyes. Probably a lot of people on the call actually were a part of the study. 14 clinics were enrolled, as well as the LAL data registry, which includes over 1,057 eyes implanted with LAL, 955 of which were emmetropic targets, and over 101 clinics enrolled, as well as the light adjustable lens plus data registry, which has 407 patients. So we're looking at a pretty big data set when we look at these numbers. And we're looking at visual outcomes. That's the name of the game, visual outcomes. So light adjustable lens versus light adjustable lens plus, monocular distance corrected vision. So we're optimally correcting for distance. There really was not much of a difference between the light adjustable lens plus and the LAL. And the thought was, because of that central asphericity with the LAL plus, is there going to be a compromise at distance? And now looking back at the data that we've gathered over the last year, not really. You're really not giving a whole lot up. Now, what you are gaining out of that, from that central asphericity, you are improving at intermediate at 66 centimeters, and you're definitely improving at near, so at 40 centimeters. So you're really not giving a whole lot up, but you are getting something in return. And I think what's most important is you're really not getting the glare and the halos that you would with a traditional EDOF IOL or a multifocal lens. So you are getting something without giving a whole lot up, really splitting those hairs. Now, binocular uncorrected distance vision, kind of the same question, different way of putting it. So proportion of patients who are achieving 20/20 at distance uncorrected. 90.4% of patients in the registry were uncorrected 20/20 binocularly, which is comparable between the LAL plus and the LAL. So really no statistically significant difference at a distance uncorrected. Also, obviously great to see. Intermediate, we do start to see a little bit of a difference. So the proportion of patients having 20/20 or better uncorrected intermediate vision, so vision at 66 centimeters, was significant, significantly improved, although maybe not a crazy amount, but improved nonetheless, LAL plus compared to the LAL. And now reading, that difference is a little bit more pronounced. We are seeing a more dramatic improvement up close for binocularly uncorrected near vision patients, LAL plus compared to the LAL. So basically, to summarize again, monocularly, we have similar distance accuracy. We have similar binocular corrected visual acuity. The LAL plus is just a little bit better, distance corrected at intermediate and near. And then binocularly, we have similar uncorrected, but the LAL plus is just a little bit better uncorrected intermediate and up at close.
Nick, can I just make a quick comment?
Yeah, go ahead.
It's really kind of a celebration of LAL because I know that it's wonderful to see that the difference between distance is minimal to none for LAL versus LAL plus. I think we do have to consider that. I think a lot of our doctors are picking LAL for patients with, post-refractive corneas, perhaps keratoconic corneas, or just corneas that are a little more challenging, and perhaps picking LAL plus for more normal / virgin corneas. And so just a little bit of a different set of patients that are being chosen for those for LAL versus LAL plus, maybe more challenging corneas than LAL plus. So seeing that their distance acuities ended up being, pretty comparable is really actually exciting for LAL to see how well those patients are getting corrected with those extremely challenging corneas.
Yeah, I agree. I mean, this is really a celebration. These numbers are, when you really look at them, they're pretty impressive. The dynamic nature of the lens, how good we can get somebody to see. We're getting patients to macular potential. And Eva, you're totally right. The LAL, we tend to self-select, and we'll get into this probably a little bit more a little later, when we use the LAL versus the LAL plus. But in our practice, we tend to keep the LAL plus for more pristine corneas. And the LAL, the traditional standard LAL first generation, is more for, well, anybody really, but especially patients who have issues, macular pathology, corneal pathology, irregularities. So you're probably right there, but it is a celebration. Now, I think the one hypothesis that I had when LAL plus came out last year is, well, because you're getting more depth of focus, there's really two things we could consider. Are we going to have to go less myopic in the non-dominant eye to achieve a desired goal? Or can we go further and still regain and retain depth perception? So looking back at all the data in both registries, the observed average myopic target for the non-dominant eye in an LAL was 1.1 compared to 0.91. So we're going almost 0.2 diopters less myopic. Eva, Seamus, is that something that's consistent with what you guys do in your practice, what you're seeing?
I do think I see that it's less myopic endpoints with the LAL plus, but I think a lot of the times in real life, it might even be less than this. On average, I think closer, like in our own practice, I know this is from a few studies out there, but I think a little bit less myopia for each, the first gen LAL and the LAL plus, probably maybe like -1 and -0.5 is kind of like where I try to get it to. So I'd say, yes, that's fairly average and maybe even less myopia than that.
Yeah. That's what I see too, usually. We're really not pushing in. I don't think we really have to. There's a couple of data points coming up here that would really kind of highlight that. The other data point here too, the proportion of patients that are 1.25 or less was obviously significantly higher for the LAL plus. So you just don't have to go as far. And I think this graph really highlights a unique thing that is a bit of a surprise, but it makes sense. So with our light adjustable lens, we have that in the purple line there. That is a less EDOF-ish, I guess we could call it. It's got less asphericity to it. And so it's more of a linear graph. So the more myopic you go, the more the higher level of uncorrected near visual acuity you go. That makes sense, right? If you're a -1, that would make sense that you can see better up close versus a -0.5. Now, the LAL plus, because of its asphericity, because of the depth of focus that it has inherent in it, there is almost a point at which you don't get as much benefit. So there's a bit of a plateau. And Seamus, just like you said, I mean, you find that you go -0.5, -0.75. That's kind of where we go. And if you actually look at the green graph here, at about -0.75, that's where you start to really not improve much. You don't see as much improvement. So I think we learned early on when we started doing the LAL plus, we thought that it operated like a monofocal lens, or a little bit more like a monofocal lens, in that it had this more linear graph where the more myopic you go, the better it's going to be, right? That's not always the case. And I have had patients where we've pushed them early on and they find that there's more anisometropia there. There's almost a bit more of a compromise than we expected. So really the need to go past 3/4 is not that, we really don't have to do that often. But the LAL traditional, moving in that linear way, I mean, you do, the further you go, the more myopia, the more improved near vision you'll have. Now, the flip side of that coin is then you're having more anisometropia and you're inducing a true monovision. And we don't use the term monovision in our clinic. We call it blended vision because the eyes do work better as a team the closer that they are. If you isolate them more, it becomes more of a monovision, like a contact lens monovision, where typically the non-dominant eye is sacrificed by about 2 diopters, give or take. But that's a more true monovision approach. So what we're looking at here, so as, I mean, Eva and Seamus and a lot of people here know, with the LAL plus, or with the LAL specifically, we do have the ability to add an optional negative asphericity to it. So since the nomogram changed a few months ago with the LAL plus, we really don't have that anymore. We don't have the ability to add the negative spherical aberration. But what this shows is that even when we did have the option to add the negative asphericity, this is the LAL plus without the optional add and the LAL plus with the optional add, there was really not much of a change. Maybe a small reduction in the, so let's say that you had a plano set eye, but you induced the negative spherical aberration as an option. You may give up a letter or two, which is not much, but it is something. However, there's really not a huge decline in distance visual acuity, but you do get a little bit more benefit at high myopia. And that's kind of what this graph shows. But I think the highlight here is that there's really not much different all the way through our normal range of myopia. So it does start to split at about 1.5 diopter of myopia spherical equivalent. But again, like we just talked about, how often do we go that far in the myopic range? We really don't that often. That kind of, again, highlights that the negative spherical aberration that you can add as an option doesn't affect the distance visual acuity that much. Now, here's what we're getting. Same idea, the LAL plus with the spherical aberration versus without it. We have a benefit of that in the lower myopia range, but then we have a little more of a compromise the further down the slope we go. So the further myopia we induce with the added optional negative spherical aberration, that's where we start to get a little bit of a compromise. But again, that comes at about 1 1/4. And so what we found in our clinic, that we really have to go -1 1/4 for a myopic set LAL plus. So I wanted to highlight some data that I crunched from our clinic over the last calendar year. So from January 2024 to December 31st, 2024, we did over 300 total, but this is the data that I was able to collect 2 months post-lock for those patients that were implanted that year. Our data was highly consistent with the registries that I just showed. So our average deviation, we know that the LAL plus and the LAL are both accurate, 0.16 to 0.173 at our target. So we're within a quarter diopter most of the time. The other thought that we hypothesized with the LAL plus is that maybe we'd get done a little faster with the plus compared to the traditional LAL. And sure enough, yeah, we had about a 5-day difference. Seamus and Eva, do you guys find that the LAL plus you can get done faster? Do you find that you reach your target faster?
Actually, I would say yes. In the last 3 to 4 months specifically, I think the average number of visits for LAL plus is almost one treatment, 2 locks, so 3 visits for that. I can think of probably 10 to 12 patients off the top of my head that was the case for. And I know we mix and match the two a little bit, but I've starting to see that the clearer corneas with the LAL plus in it actually are less visits overall. And I think maybe Dr. Kim can attest to that as well.
Yeah, I would say that when I'm counseling my patients, I take every opportunity possible because we usually plan. I mean, 88%, I think, of patients nationally are picking blended vision. We see a similar trend in our clinics. And so our patients are motivated to have as little dependence on glasses after surgery as possible. So they're in for the blend. And if their corneas are healthy, usually, pristine, I will encourage LAL plus in the non-dominant eye. I do tend to not aim for hyperopia in that eye. I'll kind of be close, like first minus. I won't go 2 minus, but I'll go first minus so that it's almost like since they're waiting 3 weeks before their first treatment, they're already kind of practicing with an LAL in their non-dominant eye with the LAL plus that has that extended depth of focus. And so they're kind of forced to get used to it, if that makes sense. And then, and these are patients who I might be a little bit worried about actually, because they haven't done monovision and I want to see if they can adjust to it. And they're kind of convinced maybe that they're not going to adjust to it, but also very motivated. So Seamus, you're really great at, just peppering in, kind of, bringing them to maybe the next point of minus or kind of, just doing just a very minor treatment, a quarter at most. And I think that they've already kind of gotten used to having a little myopia there. They've got their extended depth of focus, and you kick in a little bit more of that near of that ad, and then they're super happy. So, and then their other eye, their dominant eye, is oftentimes I will pick an LAL plus. I'll suggest an LAL not plus, just an LAL for their dominant eye, so that they can have that pristine distance. We have some patients where we will do LAL plus in both eyes, and those tend to be our younger patients who come in with high hyperopia or high myopia and are there for refractive lens exchange and are somewhat pretty adamant that they do not want to have monovision of any kind, blended vision of any kind. And so I like to do LAL plus for them so that they will have that extended depth of focus, and that maybe Seamus could, again, pepper in just a little, the most minimum amount of minus, so that they might not even notice in their non-dominant eye, and get them a little bit less dependent on readers, for instance. Sorry, long answer, guys.
No, excellent insight. I mean, the thing about the LAL too, it's not a true monofocal. I mean, there is about a diopter, I think it's 1.4 diopters of depth of focus inherent in it without the optional add. So you can add a little more depth of focus to the standard LAL to get another maybe quarter-ish. And then with a little bit of handiwork by Seamus, we can just kind of blend it in just enough. And the LAL Plus, it has about 1.6 in it. And that's about the equivalent of a Vivity. I mean, the Vivity is a great lens, and it does have depth of focus to it. So if you're already getting 1.6 diopters of depth of focus with a little subtle kind of nudge in the myopic direction, you can do pretty handy work. And you don't have to go all the way to $1.25, a buck and a half. That tends to be too far for most people. So with the plus, back to the original, the note here, a question that just came through was the average number of days until lock counting the operation date. Yes. So what I have here is from surgery until final lock-in. That's what that is. With the LAL, we have to be a little more careful about where our final target is. The distance eye is going to be plano. That's always going to be plano. You always want that as not always, but for most of the time, most of my patients want at least one eye to be plano. So you know where that target's going to be. But the near set eye, that's a moving target. So I always use golfing as an analogy. It's like we're putting on a golf course. Well, the hole sits where it sits. Now, with the near eye, if we're putting, we have the luxury of moving that hole. If we don't like where it's at, we can move that hole wherever we want it to be to make it easier on ourselves. But it's a moving target. And so for the LAL, because there's not as much depth of focus, that hole is a little bit smaller. And so we have to be a little bit more precise with hitting it. The LAL plus, we have a bigger hole. We don't have to be as accurate because depth of focus works in two directions, both plus and minus. And so we tend to reach that final endpoint faster. And I was suspicious of that. And actually, when I looked at my spreadsheet and actually ran the numbers, sure enough, yeah, we're about 5 days faster. And then again, to add to the previous point, the average near target with the LAL plus, we are definitely less. It's not a lot, but it is significant, about a 0.12 diopters, so an eighth of a diopter less myopic on average with their LAL plus. Now, that's not for everybody, but for most of my patients, we are getting less. So just a couple little final points with some clinical pearls here, and this is not just my clinical pearls. This is a number of surgeons and optometrists who are involved in this kind of brain trust on what to do or how to do it. And we'll talk about this again after we kind of go through these. So lens selection, this is true for our practice, especially. We use LAL eyes for eyes that we could normally do a monofocal or a single toric vision, toric lens. The LAL plus we tend to view as an eye that could handle a Vivity or a multifocal, some sort of depth of focus or multifocal lens. These are eyes that are healthier, no comorbidities, no large angle kappa. They're less likely to be targeted with significant myopia. So our patients who are not, extreme, they don't have a huge a potential for compromise. We stick with the LAL plus for those, but eyes that do have comorbidities, they have macular pathology, they have glaucoma, significant dry eye, then we'll stick with the LAL. Surgical planning, our A constant 119.1, and we're targeting plano. You don't have to use the old A constant 118.4 where you kind of had to expect to end up a little bit more hyper. With the new A constant, you target plano and you get it pretty accurately. The IOL centration is definitely more important for the LAL plus because of that asphericity. We do need to make sure that that lens is perfectly centered. Our LDD targeting, our distance eye is always going to be plano. Keep in mind, especially if you're refracting in a short lane, that we sometimes can be a little bit over minus. So being a little plus is not a problem. So if you end up at -1/4 in your short lane, in the real world, that behaves like -1/4 to a -1/2. So you tend to be more myopic than we expect. So if you're plano or even on the plus side, that's not a bad thing. Those patients are usually more comfortable with their distance visual acuity. Now, in the myopic near eye, just like I mentioned, that we don't have to go that far. So with the LAL plus, -0.75 on average, I wouldn't go much more than -1, -1.25 seldomly. But the LAL, you can be a little more comfortable going a little farther. You may have to get that patient's desired visual outcome. So for the LDD, so the technique pearls, make sure you've dilated. That's a no-brainer. You got to be able to see the lens. You need to see both haptics and an edge. You want to avoid putting too much pressure with the contact lens and vignetting. Vignetting is where we're obscuring the view of the camera, basically, or the view of the light delivery device with the edge of the lens. Use the pattern assist if able, and then focus on the haptics. The haptics are your Z target. So you can see X and Y, the Z is your haptic. You want to make sure that you're a proper depth. And then active shield. I get this question all the time. Do you really have to wear the glasses? You really do outdoors, and every clinic's different, but the active shield does provide redundant protection, but it's not the whole thing. And it does wear off over time with UV exposure. So it's not really a time per se that wears it off, but it's UV exposure cumulatively. So lock-in is still required. You can't just do your third treatment and then that patient can disappear. You do have to lock it in because the active shield only provides redundant. So guys, that's the data. Can you see me again?
Yep.
All right, cool. So yeah, we kind of already touched on it a little bit. The numbers really are, I think, remarkable, and they really show how we use these lenses. So Eva, why don't you start? What exactly are you looking for when you're determining who's an LAL plus candidate versus an LAL? I mean, which you kind of already touched on it, but why don't you kind of circle back to that?
Sure. So I think it's a huge passion of mine, actually, when I'm meeting with my cataract surgery patients or my refractive lens exchange patients, it's almost like it's a challenge for me to walk in and quickly assess and understand the patient. So first of all, I'm soaking in their body language, their the manner of their speaking. Are they pressured? Are they super relaxed? But generally, I'll start to get a feel from the patient that, they want to be pretty involved in their destiny. Like that's a nice way of saying they like to be in control. And that's okay. That's not a bad thing. And it's also a nice way of saying type A. So I don't like to throw out type A to the patient or controlling, but I'll use that phrase, I feel like you want to be in control of you want to be a part of your destiny. It matters to you what your vision is going to be. And there's an amazing technology that will allow you to do that. And the face lights up. The patients are like, yeah, that's what I would like. It's important to me. These patients have already expressed that they would like to have a technology that, gets them as much independence from spectacles and contacts as possible. Sometimes patients will come in and talk about really not wanting the halo profile that their neighbor has, that they're, they've heard about kind of not great things said about multifocal technologies. And so, that will always kind of push me toward talking about light adjustable lenses. I am not someone who comes in and sort of talks about every single lens that I offer because there's so many lenses in my toolbox. I don't just use one or two. I actually love the fact that I use like 7 or 8 options, but I think it's my responsibility to get to know my patient pretty quickly and accurately as I can, and start suggesting ones that I think would be great. So once I suggest those and I sort of feel like I've convinced the patient that that's one that they will gel with, I will quickly mention some other technologies. So just so they don't think that I left anything out, but I'll say, I don't think this one's great for you because of this reason. You said something about halos. I think this is not good for you. So I will kind of touch on them quickly. And frankly, the reason I do that is there have been times where I didn't judge it correctly. And then the patient will say, well, that one really actually sounds pretty interesting. And so then we'll shift and go in a different direction. So I think it's important, again, for the surgeon to give a recommendation to the best of their ability, but also not omit anything that could be of interest.
That's a good point.
Yeah.
A comment or a question just came in, and I guess reminder to everybody watching, feel free to please ask questions. We want this to be interactive. And I think you touched on this a little bit earlier, but how often do you mix and match with LAL versus LAL plus between eyes? Do you do that quite a bit?
Yeah, I would say it's my routine. Okay. If I have a patient, for instance, who has had no corneal refractive surgery and has like a healthy, pristine cornea, that is my typical plan. I bring it up to the patient because I like my patients to be informed. I don't go into much detail about it, but I will just explain that if we do a mix and match of LAL plus in the non-dominant and LAL in the dominant, it will allow them to have extremely sharp vision in their dominant eye and less difference between the eyes. The split between the eyes will be minimal compared to if we did any other plan. And so they love that, and I'll say it'll preserve your depth perception as much as we can, understanding that there's really no way that we can get you out of that, dependence on reading if we don't try to blend your vision. And they're, they buy in almost every time.
So a counter argument to that.
Sure.
What about patients who their eye dominance flips? Do you ever experience that?
You're talking about.
So if you do an LAL in a dominant eye and then a LAL plus in a non-dominant eye, do you ever find, because I've experienced that where I've had a patient, we're in Wisconsin, everybody's got a shotgun. I always ask them, like, which way do you shoot with? And, I've had it before plenty of times where they think that their right eye dominant. They may scope with their right eye, but then they're like, actually, you know what? I kind of do one of these things. And then their left eye ends up being
Yeah.
dominant. Does that ever come back to bite you, or has it always worked okay with that strategy?
I feel like we discover it pretty quickly, like in the consultation. I I spend a lot of time on it actually. I don't just sort of breeze over it. I don't let anyone else do it for me
Mm-hmm.
ever. I don't trust anyone because sometimes it's tricky. Sometimes their dominance is unclear, like you're saying,
Yeah. Yeah.
where they say they'll like take a photo with a disposable camera with one eye but shoot with the other, and so I just really try to dig in. Yes, there's
Mhm.
probably a handful, I can count on one hand, patients where we remain confused, but I feel like it's almost always that we're expecting that it could change a little bit. And so if I'm in that situation, Nick, I will just do LAL in both. I won't pick the one that I think, it has to be pretty strongly non-dominant before I'll pick the LAL plus.
That makes sense. Seamus, so let's switch it to the post-op then. So when you get to the light adjustments, let's say you have a patient who has not had any treatment yet, and so they're theoretically close to plano. We had a question that just came in about contrast sensitivity. Did they ever complain to you about differences in contrast sensitivity between the two?
That's a great question. And I would say I've never had a patient be able to put that into words themselves. But no matter what, every time they're coming in, I'm refracting them and then showing. So we do like a couple baseline refractions before day one. So I can show them, hey, this isn't your final outcome. We have a lot of work to do here. And then I'll ask them if they actually notice that same phenomenon when both eyes are corrected for distance. And then just try to kind of point it out that way, that like, hey, when both eyes are seeing what they're supposed to be seeing, you can't really describe that same phenomenon to me, can you? And then they, more often than not, they can't. And then if they are like if they're remaining adamant about it, that it's a little bit different, is I just talk about how the plus is going to be there to read. And when you are going to be binocular with this, you're not comparing right to left, and you shouldn't really be able to constantly pick up the difference. If you are looking for it, you're probably going to find it. But I would say the majority of people that are mix and matched are not complaining about contrast sensitivity difference. Maybe at the beginning, they're very astute and really comparing right eye to left eye, which I have a whole conversation with them about. You can be as picky as you want in the first 20 days, but we haven't started to change some things yet. This is just so I know where to start when we get it going. So there are some people that are like a little bit more detail oriented than others, like all surgeries are, but I don't have patients as much before treatment one with those specific complaint types. And if I do, I kind of do what I mentioned: refract, show them both eyes distance. What do you see now? More often than not, that complaint falls off. And also more often than not, 6-8 months down the road after lock-in, they can't even bring it up to me again, because that's just something that they've adapted to.
Yeah, I really try to make it a point. I think you bring up a good thing. Even when it's LAL versus LAL plus, and then certainly when you do start to do the light treatments, you are making the eyes different, and they are working with a little bit of a different priority individually. So I tell my patients straight up, don't do this. We call this the refractive salute. When I walk in and they're doing that, don't do that. It's like asking me to throw a baseball with my left hand. It's going to look terrible. I'm a righty. But if you ask me, do I notice that I have one hand better than the other at any given point throughout my day? No, it's only when I look at it to be isolated. So you're only doing yourself a disservice, I think, if you're looking for the difference. So don't. And because also neural adaptation is a very, very real thing. And it's different. It takes longer for different people. Some people get it right away. Boom, they are comfortable with the imbalance. Others, it takes time. And it can definitely take a while. So Seamus, back to you. When you're considering doing an LAL or an LAL plus, I mean, is there certain lifestyles that really mesh with this? And then between the two, between Eva and Seamus together, surgeon OD who's doing the adjustments, do you guys communicate during that process and decide how to do this? Or is it once the surgery's done, Seamus is on to you? Or how does that dynamic nature work?
I still think it's a team effort most of the time. She's pretty organized with the initial plan that was discussed at the initial consult before the lenses are implanted. So that's kind of my scaffolding that I will work on. And then most of the time, if I'm running into situations, I will bring her back into it for most of the time, or I will at least inform her like, hey, I gave Jimothy a little click of minus in the left eye in the LAL+,
nice guy.
and then I'm going to check it out here next week or so. And if I do some changes off of kind of the main plan, I don't bring them back 72 hours later. I give them like a full week to go out and try it that way. So I do have a little autonomy with it and the decisions that are made with it, but definitely on patients that are a little bit more type A, a little bit more particular with their outcome. Maybe they weren't super happy with like the last light treatment that they got. I will bring Dr. Kim back into it. And that is kind of like it does feel like a nice safety net for the patient. Sometimes they just need to hear it from the surgeon, and I'm totally fine with that. But I'd say I'm driving the car after she puts the lenses in. That's probably 80%, 90% happening without the surgeon's attention prior to the decision.
And this makes me realize that I think it's really important. It sounds like a no-brainer, but on the EMR that we as the surgeons leave incredibly clear notes. If you're not the one who's doing the treatments, or if there are multiple people who are going to be involved in the pathway, the journey for the patient, the notes have got to be good. So my consult notes, I think they're okay, right, Seamus? I always talk about dominance. I talk about what they do. I talk about the plan. I really want Seamus or Dr. Boon Kong is our other OD who does a lot of my treatments to have the benefit to understand what our goals are. And we see each other enough that if it's unclear, then they can absolutely ask me in person or text me and say, like, this one's a little confusing. Like, what is the goal? But it should be very clear. I think it's the surgeon's responsibility or whoever did the consultation to make it very clear what the goals are. Now that can change. We all get that. Sometimes patients think they're going to go distance in both eyes and they're convinced, but and then they actually want a little bit of micro or mini monovision, but and that's wonderful that they can. That's the whole point of it, right? But I think that we really need to make sure we're communicating with each other because this is such a team effort, you guys. Like it's actually a very beautiful thing if the team works together and the workflow is smooth. Patients are so happy that we're communicating to each other, that we're talking to each other for their benefit.
I think the team approach is, this technology highlights that. I mean, my clinic partner, Dr. John Vukic, him and I are in communication all the time. And it starts with a really good surgery. And it starts before that. It starts with really good biometry because you still want to be close. But the beautiful thing about this technology is you don't necessarily have to be perfectly close because you do have a little bit of a fudge factor. How long, Seamus, so to the light treatments, how long do you give in between? You said 3 days, or do you do it more?
I'd say I have 2 half days a week of 14 patients right now. So I see about 28 appointments a week. It doesn't mean 28 people. And that's Monday and Thursday. So minimum is at least those 4 days. And if it's very, very patient dependent. If that patient comes in and they're like, this was the best thing ever, like I'm ready to lock, like we're pretty good about it that way. If a patient, I always give patients like, hey, the beauty of this is all you have to do is keep your UV glasses on and you can test drive this as long as you want. We have, and I'll make examples like our post-RK patients. Sometimes this is a 10-month process. Sometimes it's longer. Not everybody, but we have had people go that long just for stable refractions and things like that. So I outline to maybe the more normalized patient, like you can decide this. There is no timeline on you making this choice. Like we can walk slowly into this, and I don't like making big changes at once. So I would say on average, I will see a straightforward patient, every 3 days, every 4 days, I will make somebody who's really test driving it, maybe every 7 days or every 10 days. It just kind of depends on, again, the patient. How reliable is my refraction? What does their ocular surface look like? Do I trust what I'm measuring? Do I trust their acuities at that time? And more than anything, do I trust their subjective happiness with their vision?
You know, once you get into it, I mean, time is your biggest friend. You have time. I mean, you do. Like putting on a golf course. Sometimes it takes a second read on that putt. You don't have to rush up and putt it real quick. There's no race. And I tell patients that all the time. Like, we can take our time. If you're not 100% sure with the decision, I'm here no matter what. If you want to take another week, that's fine. We separate ours out every week. So we do our first adjustment at 3 weeks tentatively. I always say that to our patients too. Everything is tentative because we want to make sure that everything is stable. Once we determine that you're stable, and 99% of the time, maybe not 99, but 90% of the time, they are stable at 3 weeks, do first adjustment, and then we bring them back. I have them scheduled in my day-to-day the same day every week. So I do Mondays, I've got LDDs throughout the day, then Thursday mornings and Friday mornings. So they have either a Monday, 5 weeks in a row, we schedule them out. And then we can cancel if we need to, if we don't need 5, and rarely do we. But we have the ability to have that same time slot. And that's really important, I think, for patients with RK or post-refractive, where you kind of want to catch them. They may fluctuate throughout the day. You catch them at that same time. So speaking of post-refractive patients, let's talk some high-level math. Everybody loves math. Higher order aberrations. The LAL specifically has the unique ability to add depth of focus, and it does that by a triggered mechanism to increase spherical aberration. There's 3 things that you have to do that. It has to be on the first treatment. You have to be moving in the myopic direction or stay neutral in both meridians in your power cross, and you have to shoot for -50 or more myopic. That will induce a little negative spherical aberration. Seamus, can you talk about how you discuss that, or do you discuss that with patients when you're doing it?
I don't go into like the level of studying it for a test that we would understand it. I do explain that this lens has a specialized feature that I trigger myself at a certain time when we're both ready for it. And that also kind of depends on, how happy is the patient with their vision. A lot of the times, what I'm finding more and more is Dr. Kim's implanted LAL Plus is actually pretty good far away and up close at the beginning. And I'm rarely changing these. Like, I'm rarely moving past that half diopter mark from the initial implantation on Plus. And then I love having that in my back pocket for the standard LAL if somebody wants a little bit more. So I kind of more say that it's a feature that I can turn on or turn off depending on the lens and patient satisfaction, which, again, case by case.
Any thoughts, Eva, about that?
So I would say the way I talk about it with my patients has changed from when I started using LAL, and there was not LAL Plus, by the way, it was just LAL, to what I say now. So initially, I would talk about blending vision and the non-dominant eye with the LAL. We had an opportunity to create a blend, an offset, so that there would be a difference in distance between the eyes, especially someone who's never done monovision and they, again, are feeling a little bit nervous about the concept. But that I could talk about, making their non-dominant eye be more myopic or, a little better at near, but I wouldn't have to necessarily make that a dramatic difference between their eyes, because we have a method with the light treatment where we could, again, bring their eye a little bit further from distance, a little bit better in near, not dramatically, and then have an extended depth of focus that would give them a rich kind of more range, so that they could potentially hit kind of a far near target and intermediate, have that, smoother range of near vision out to distance. So that's what I used to say initially, again, when I didn't have LAL Plus. And I feel like in our patients where I'm not routinely using LAL Plus, I'll use an example. a post-LASIK patient, so it doesn't even have to be RK or keratoconus, but a post-LASIK patient, I will routinely not use LAL plus. I will use LAL in both of their eyes. And that's where I will, kind of discuss that extended depth of focus, that we have the ability to do that. And I will say that that it's typically something that we will go ahead and utilize during our first treatment, because we want to see if we can take advantage of that extended depth quality with treatment number one. And we all know that most of our patients, because I'm aiming for right around plano, even in their non-dominant eye or maybe first minus, they will need in an LAL more than a minus 50 typically. And so they'll move towards myopia at least that much during their first treatment, and we can take advantage of that extended depth. And I feel like it's worked out really well, Seamus, don't you think, that with LAL patients, and really no complaints that I can think of specifically?
No,
Go ahead, Seamus.
Real quick. Like, it's kind of hard to simulate that with the contact, right? Like, I know like there's a lot of that trialing, but you can't really simulate what that depth of focus is going to be like in the real world before it happens. But one thing that I've noticed about the outcomes is that once that depth of focus is turned on, some patients are still seeing 20/20 through an eye that I'm refracting minus 0.5, minus 0.75. Mm-hmm. Some of them are like 20/25. Some of them, like, it's not that giant discrepancy that you would have with like a standard IOL or maybe even LASIK at some point in the past, where you're measuring like minus 150 in plano, or that would give you like a 20/70 eye, 20/60 eye in the distance. It actually functions really, really well at like 20/25, 20/30. Then you give their dominant eye back and they're like, okay, I get what we're doing now. And it's a very, very small difference between the two eyes versus a traditional monovision.
So I was asked to clarify how you do that. So this is only for the LAL, not the LAL plus that used to be, but that's changed. The nomogram has changed. So only LAL. First treatment, you're moving in the myopic direction or staying neutral in both meridians, and it has to be targeted for negative 0.5 or more myopic. So by doing that, you're hitting those three things. You are inducing about a quarter or so, maybe a little bit more added depth of focus. And so when would you maybe consider not doing that? Is there instances where you would be careful about that?
If somebody's happy with things the way they are,
yeah,
right. And if they can, like, let's say this would be where like a contact lens trial is super helpful. Like, I can give you maybe minus a half and not cross that line, but that also means I'm not able to turn it on. So you have to be happy with where you're at and less than 0.75. But that would be the instance.
And typically I would say, I'm not treating as much. I will say I've treated for about three years, and did quite a bit of treating. I really wanted to understand it as the surgeon. And now routinely our ODs are doing the vast majority of treatments. But when I was treating, I would disable the EDOF with RK patients and, pretty difficult corneas. I just thought it was potentially going to create less satisfaction in vision potentially. So I would be very careful and try to keep it very clean and turn it off. But other than that, is there any other reason, Nick, that you tend to turn it off?
That's mainly the reason. I mean, aberrated corneas, post-refractive, especially hyperopic LASIK. I mean, because think about what those eyes already have. They already have negative spherical aberration included in their corneas. So the advantage of adding more, really, we already saw it with those graphs earlier with the LAL plus. Once you hit a certain point, it's kind of counterproductive and it doesn't really help. So same thing with the eye as an optical system as a whole. If you already have a ton of negative SA, why add more? All you're doing is asking for a problem. And that's when you're going to get the glare. That's when you're going to get the halos. That's when you're going to get those complaints that we cannot fix with a pair of glasses, right? Low order aberrations are myopia, astigmatism, prism. That's all low order aberration. Anything you can do in a phoropter is a low order aberration. If you still have optical problems that you can't fix with a pair of glasses, that's a higher order aberration. So those eyes, we don't need to add more noise to the system. Now the plus, not the LAL plus, but the plus side, the pro to our con, sometimes aberrated corneas have advantage of depth of focus naturally. So RK, right? So the example you mentioned there, never would do the added depth of focus for those patients because those corneas kind of behave like multifocal contact lenses. They have depth of focus, and miraculously, I can have patients who are like way plus and they're still seeing J1. Now, why is that? Because they've got a lot of plus or minus negative spherical aberration. So we don't need to add to that. And those patients are already very happy. The other reason why I wouldn't do it is if somebody can't commit to one eye being dominant. So if they're really wishy-washy, because once you trigger that, you can't undo it. That is something that will always be there. And you can fix that low order aberration wise with a pair of glasses, or you can undo the refractive targeting, but they will always have that negative spherical aberration included. So if they have a little bit of a wishy-washy attitude about it, they're not sure if they want to commit one eye to being reading or not, then I won't do it. We'll just give them maybe a little nudge, but we won't hit that threshold, and there you won't have that negative spherical aberration. On the second treatment, then we can go further. And so that might be a case where we may need two, maybe even three adjustments. Question that just came in. So if for some reason you choose to reverse the added myopia, what happens to the added depth of focus? Does any of that benefit remain? The depth of focus does remain, just like I mentioned. You can have that. So I have heard of doctors use that strategy. Go to that negative 50 threshold and then back it off. So you've got depth of focus in one eye, but you're not as refractively compromised in the myopic direction. You could do that. I don't typically do that. Usually if we're going to do that, we're going to do a little bit of a blend anyways. But I suppose you could do that. Eva, as the surgeon, is there any difference intraoperatively between the two, LAL versus LAL plus? Do you find that there's any nuance? Or nope. LAL compared to other lenses?
Oh, yes, absolutely. Okay. So LAL to LAL plus, no difference. I always kind of look at the LAL plus to see if I can see a, central elevated area. And every now and then I'll get a little flash of some, like a just notable circular area, but generally no difference. And I've actually asked my technicians who fold the lenses if there's any difference in the way it feels. And they always say there's no difference. But yes, gosh, LAL, I implant a lot of them, but they just continue to make me just a little bit nervous when they're going into the eye because when you are inserting the IOL into the eye, unlike a lot of the softer, gummy acrylic lenses, this lens comes out, halfway out of the inserter and it just flings open like a plate. And it never has yet, but it feels like it's going to open up so quickly that it will break the bag. So I am so careful about making sure that the capsular bag is as full can be with viscoelastic so that the haptic, doesn't sort of tear through the bag. It feels like if it's underinflated that, you're really asking for some trouble there and it's going to break through the posterior capsule. It never has though. The nice thing about the three-piece silicone lens is that if there is rupture of the posterior capsule, unlike the one-piece soft acrylic lenses, you can choose to use this IOL still in the eye. You don't have to remove it. You can place it in the sulcus. You can decide whether or not to optic capture. It's probably a good idea to do that if you can for stability's sake, so it stays centered. But it's really nice because when you have a posterior rupture with a typical one-piece lens, that lens is not allowed to stay in the sulcus. So you have to pull that lens out, cut it up and take it out, and then pick another acrylic or silicone three-piece lens to put into the sulcus. So,
yeah, by doing that, you would have a higher chance of inducing surgically induced astigmatism. Becomes a lot more problematic. I guess if you've never seen it, Seamus, my next question was, would that, if there's a sulcus placed LAL, would that change your strategies during the light treatments? I guess hypothetically.
thank goodness that hasn't happened yet, as you said. I think I'd be a lot less aggressive with treatments, like definitely going to, like cross my T's and dot my I's with that. I think yes, I'd probably, even the first time that I would experience that, I'd probably bring like a member of RX site into the fold for some counseling on that. Just maybe not something I want to troubleshoot by myself. And I'm not ashamed to say that. I think that would be, stakes are a little bit higher, and you want to still give them the same outcome. So I don't know. I'm sure that one day something will come across my plate like that, but I will
hopefully not. Hopefully not.
Yeah.
So I'll make a comment about that. I have treated a sulcus IOL. I've treated several sutured light adjustable lenses in patients who have had dropped lenses, and by having a retina doctor. I have a really great friend and colleague in the community who has done vitrectomy, and then he actually cares about refractive outcomes. And so we have this little partnership where he will do Yamane fixation of LAL, and then I'll do the treatments for the patients. So that's been a nice partnership. He'll send them to me for the treatments. And it really is like, I think the only difference is these patients are so grateful to have the opportunity after a dropped lens, usually because they had trauma or like a white cataract or dense cataract, and they end up having this like amazing 20/20 vision, after all the light treatments. Like, so that has been really exciting for these patients. I wanted to make one more really quick comment, which is, have you ever, Nick, had a patient who has like really intense anterior capsular phimosis, really, really scarred to the point where you feel like they're not really, the light treatment isn't getting through that scarred anterior capsule? Has that ever happened to you?
No, but I guess in that situation, I would be a little concerned that the lens might tilt, or there might be some torsion there. I've not seen that. Have you seen that before?
Yeah. So I had a patient who had just really notable, there were actually two that I can remember, had notable phimosis. It was, almost like whitened. One of them, we ended up having to YAG her.
Sure.
And it opened up and we could get the light treatment in because she wasn't responding to her treatments. And then I had this one gentleman who had keratoconus, post-intax, post-cross-linking, and some just annoying phimosis. And he wasn't responding to the cylinder correction that we were trying to do. And with the old LDD model, you can look in the oculars and see exactly where the green light is trying to do the treatment along that specific axis. And I just noticed that the light was shining right over the most phimotic parts. And so I would sort of roll my joystick up and down to sort of almost feel like I was scooching the light treatment kind of up under and down below and sneak in the light as much as I could. And I did that patiently week after week. And we were actually able to hit all of his cylinder correction. It just took a long time to do it. So I just wanted to, and I was going to YAG him as well if we needed to, but I didn't end up having to YAG him. His phimosis was not as intense, but I just felt like if we could just kind of rotate back and forth, up and down along the lens and get some treatment in there, that we might have some hope of it working. And I shared that with RX site, but I thought it was just pretty amazing that we could sort of come up with that solution.
That's thinking outside the box.
Yeah, it was really cool. I was like, maybe this will work. And it actually ended up working. Just took like 3 visits to do it.
Yeah. So in that, I would consider doing a YAG in that case, but with that, you would certainly have to be sure that the lens did not tilt. And I guess doing the adjustments, I'd pay special attention to the topography to make sure that your cylindrical axis is stable. And that, again, is an example where time, I think, is on your best friend. You just wait a little bit, make sure things are stable, make sure 1 + 1 = 2. And when it does, then you can go through with the treatments, but it'd be a little bit longer of a process. But thinking outside the box, that's an interesting strategy. Glad it worked. We're coming up on an hour, guys. Thank you so much, everybody, for joining us tonight. Seamus, Eva, especially you guys. Thanks for your contributions and everybody that contributed to the chat. This will be recorded. It is recorded. It'll be up on the peer-to-peer.academy website. And keep an eye on your inbox for the one next month. Have a good night, everybody.